Today on the Regimen, listen in to find out how pharmacists are working with community corrections and specialty courts in Massachusetts.
Hi, pharmacists and friends. Today is Tuesday, January 30th, 2024. Welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen in to find out how pharmacists and pharmacy students like me can improve population health, health equity, and patient care through advocacy and education. My name is Cassie Capezza, and I'm a final year pharmacy student at the University of Rhode Island, working with the Rhode Island Department of Health alongside my professor, Dr. Bratberg.
Hi, and I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research here at the URI College of Pharmacy and the Academic Collaborations Officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, the University of Rhode Island, or any other organizations affiliated or funded by our guests.
Today we'll be talking about pharmacists' role in the court system, specifically specialty courts, including a type called recovery court, featuring speakers who work in Massachusetts. We're joined today by our incredible guests, Dr. Joe Sawicki and Dr. Kate Pivovarova, who I will let Dr. Bratberg introduce.
Great, thanks, Cassie. So very excited to have our guests here, two guests on the regimen here. Dr. Sawicki wants to be called Joe, so we'll call him Joe. So Joe was a hospital pharmacist working for 14 years at St. Vincent's. He was certified in pain management, which evolved into treating and managing patients with substance use disorder. Right now, though, and so excited to have him, is a consultant pharmacist for substance use disorders at 4Health Consulting at the UMass Chan Medical School, working with recovery courts and the Massachusetts Center of Excellence for Specialty Courts, and importantly, parole community pathways, and is a medication content expert, like all of us pharmacists here, and a liaison for community partners working with justice-involved individuals. So we're here to replicate Joe for all our listeners here. He's also a faculty member at the Massachusetts Center of Excellence for Specialty Courts, which features some of the work being done in those courts, and we'll post a website for you guys to go to on our socials. So thanks for being here, Joe.
And thank you very much for having me. I'm looking forward to discussing all aspects of my current role and how it's assisting and helping people who are justice involved.
So next up is Kate. Kate is very esteemed, and we're very happy she took the time out of all of these things to come with us. She is a licensed clinical psychologist and an assistant professor in the Department of Family Medicine and Community at the University of Massachusetts Chan Medical School. Her work focuses on implementation science techniques, one of my favorite things, to improve access to care for individuals with substance use and mental health disorders, particularly those with criminal legal involvement. She's the recipient of a National Institute on Drug Abuse, or NIDA, K23 Career Development Award, a UMass Chan Medical School KL2 Award, and is a co-investigator of a NIDA UG1 Center grant to examine the statewide implementation of medications for opioid use disorders, or MOUD, in jails. She's also the site co-principal investigator of the Education Corps for the NIDA UC2 grant that provides research training for junior investigators, clinicians, and criminal legal scholars in correctional health settings, so a teaching education role there, and is an academic director and board member for the Academic Consortium for Criminal Justice Health, a national organization that advances healthcare research for those involved with the legal system. If that's not enough, she's also a faculty member of the Mass Center of Excellence for Specialty Courts, which again features some of this work being done. So that is a mouthful, Kate. You're amazing and excited to have you with us here.
Thank you. I'm honored to be here.
Many of our listeners probably need a little bit of background on some of the terminology we're using today, especially when talking about drug courts, specialty courts, and problem-solving courts. Kate, can you provide some national and state context for these terms?
Absolutely. Terminology is always changing, and we want to stay on top of it to make sure that we're always talking about the same thing. So in Massachusetts, we refer to these as specialty courts, with the recovery courts, which is what used to be formerly called drug courts, being the most common type of specialty court. Nationally, the term used more commonly for all specialty courts, including drug courts, is problem-solving courts. Now, there are many different types of problem-solving courts, and in Massachusetts, specialty courts, with drug courts, or as we refer to them, recovery courts in Massachusetts, being the most common. And I'll just note that the reason we talk about them as recovery courts as opposed to drug courts is really to try to reduce stigmatizing terminology for individuals who are enrolled. Other types of specialty courts, both in Massachusetts and nationally, include family treatment courts, mental health courts, housing, veterans courts. And so since we provide services and perform research in Massachusetts, and it sounds like you as well, will be talking about them as specialty courts. So thanks so much.
Thanks for clarifying and explaining all the different terms. So specialty courts are an excellent approach to public health by improving access to treatment of substance use disorder, or SUD, for a specific population. When people think of pharmacists, they think of community pharmacy chains like CVS or Walgreens that dispense medications, counsel patients, and administer vaccines. Pharmacists also work in clinics and hospitals with teams of other healthcare professionals. We don't typically think of them in courts, though. Joe, what made you transition into this pilot program, and how did you come across the position? What was your primary motivator to accept the job?
So my passion started back with ensuring adequate pain control when I started out in pharmacy, and it evolved into learning everything I could about pain management. I started seeing more and more persons who were struggling with substance use disorder who needed adequate pain control. And there were a lot of misconceptions regarding how to best treat acute pain, especially around the surgical arena. For example, patients that were on methadone, a lot of providers out there were already on an opioid, so they don't need anything else to treat the pain because the pain was being treated. Other suggestions were being told to hold people's Suboxone for 3 or 4 days prior to surgery, or a week prior to surgery. So there were a lot of misconceptions that were out there. The position itself came into my email, caught my attention, went ahead and applied, and I was fortunate enough to get the position.
That's great. Yeah, there's I think as Cassie and other of her colleagues start looking for jobs, we're always happy to hear that those things are out there, and we always try to distribute them to our networks. It sounds like you're sort of a myth buster, so I appreciate that, and I think that that makes you fit for this role. So Kate, can you talk about how you envisioned, again, Cassie just talked about what pharmacist's role is. How did you get to think of how a pharmacist could be in a specialty court and what their role is in the criminal legal system?
Yeah, so I think for that, let me give you a little bit of background on what specialty courts and especially recovery courts do, and then you can understand how the role of a pharmacist not only fits in really nicely, but is in fact critically needed in this particular context. So recovery courts, or really all specialty courts, are diversionary programs that leverage legal sanctions in exchange for mandatory and court-monitored substance use treatment. So, as I've already said, there are sort of a number of different types of specialty courts, but really most of these, and in particularly in Massachusetts, are post-arrest, where the individual essentially enters into what we would think of as like a specialty probation program, where if they complete the program, they will not be prosecuted for the charge. On the other hand, if they do not complete the court, which is sort of common and unfortunately a big problem, the charge remains, and there's some sort of a deal that is usually worked out. Now, specialty courts are in fact quite common across the United States and really worldwide. We have over 3,400 nationwide, with more coming on board every single year. And so to contextualize the reason why we would want a pharmacist in there is, let me just sort of explain what have been some of the changes happening over the last decade or so. So to go back to the very beginning, drug treatment courts started out in 1989 in Miami, so have been in existence for over 3 decades now. And there have been some really notable changes. And perhaps, and certainly from my perspective, one of the most notable changes has been to access to medications for opioid use disorders. So traditionally, recovery courts have been resistant to allowing participants to receive various types FDA-approved medications for opioid use disorder. About 10 years, big changes started to take place. One of the first changes was really how federal agencies and leading national organizations started to sort of describe what needed to happen in specialty courts. So for instance, federal funding agency said, in order to receive monies to support a specialty court in your state, you needed to allow individuals to receive medications for opioid use disorder. Not that they had to actually take it or get it, but that they had to receive it. Second, we had the introduction of extended release naltrexone. And as with all other criminal legal agencies, the courts were concerned about potential for diversion, especially to other participants who are similarly struggling with addictions. And injectable monthly medications were able to ease some of those concerns. However, as we know, extended release naltrexone is just one type of FDA-approved medication. And in recent years, there has been increased acceptance and recognitions that individuals should have access to all types, not just extended release naltrexone, but really all of the medications that are approved for medications for opioid use disorder. And so some of this has been driven by changing landscapes, lawsuits, and increased acceptance of MOUD really across all touch points in the criminal legal system. And yet, and this is where the pharmacist role comes in, right? Well, we know that despite the increased acceptance, and we now have research that supports that there really is increased acceptance across court and removal of automatic prohibitions of MOUD in recovery courts, nationally, we continue to see fairly low uptake of MOUD. Why? Well, we spoke to court staff and we learned that it's not so easy to make connections with MOUD providers or to understand the treatment that recovery court participants are receiving while in MOUD treatment. And two key issues kept coming up. One is collaboration between criminal legal agencies and MOUD providers is really, really hard. And two, we have a need for addiction experts, especially around pharmacotherapeutics. It's really high. We need people to understand it and someone who can explain to the court. So staff wanted someone to talk to understand what it means to have polypharmacies, how do we use off-label medications, medication interactions, and how to interpret urine tests given the complexities of MOUDs. And to answer that, working together with my mentor, Peter Friedman, and also you, Dr. Bratberg, we developed a proposal that we brought to Massachusetts to use a pharmacist as a community liaison between recovery courts and MOUD providers. And since then, we have seen some really tremendous acceptance and really recognition about the critical role that pharmacists can play in doing this type of work.
I think it's really great to hear some of the history behind specialty courts and how they're continuing to evolve. Just thinking about implementation of these specialty courts, it's important to educate the court staff on different medication treatment options for SUD, as you mentioned before, particularly opioid use disorder or OUD. The treatments, like you said, are buprenorphine, naltrexone, and methadone. They're life-saving treatments that are dramatically underused at this point. Joe, what are other different members of the court staff who you may be providing this education to?
Yes, well, when I'm embedded with the specialty court team, the team, it can vary, but the core team usually is the judge, the probation officer, the defense attorneys, the district attorneys who do the prosecuting, court clinicians, court coordinators, and it might be various people from the community justice support center staff that are tied into the courts that help people with programs while they go through the recovery court, specialty court process. And of course, there's also the participants themselves are available to answer questions and supply education for them.
Yeah, thanks, Joe. That's, I think what in preparing for this podcast, I've been amazed at just how many people, are doing this, like the number of courts, the diversity of courts, and each one of those expanding 3,400 courts has a whole set of staff. I mean, what's interesting is these are folks who are interacting with the people who are, criminalized for using and distributing drugs and who often have substance use disorders. It's really an underserved health agency. It's really shifting from sort of what harm reduction is, shifting from a punitive approach to a treatment approach, just sort of, I think everybody is interested in that. So it's great, once you find you provide education to one person, then everyone else wants the education and sort of overfill the grant, and that's good for Kate and others because then we get more funding to do more work, right? So Kate, how did this expand to include other core professionals? Was it sort of inevitable, or did you have to work at it? And where would you like it to go from here?
Yeah, so that's a great question. We started out with focusing on recovery courts, and we thought, let's try this out. There's some interest, but who knows? But as we had Joe enter the courts, what we saw was that there was, in fact, great interest, not just from the courts, because courts are just one piece of the criminal legal puzzle in the community at large, right? And so we had a number of other agencies express interest in having someone that can sort of describe to them what is happening for individuals who are receiving medications for opioid use disorder. What does it mean for people struggling with addiction, and what sorts of treatments they're getting in the community? And so one of the areas that we expanded was in other community correction systems, which was in parole. But really what has happened is that Joe has started to provide education, not simply to the staff that are involved in, say, the courts and the specialty courts, but really to the probation department. And there are different ways that we've tried to do this. And the reason we've expanded is very much because there's a great need for this, right? We are not saying that we want probation officers and court staff to be able to know every single thing there is about medications for opioid use disorders. But at the same time, we want to be able to teach them and have someone that can come in as a consultant and say, here's this unusual situation that happens, or there may be this particular interaction that occurs, right? So we don't want them experts, but we want them to understand enough to know that this is unusual, who they can go to, and have someone that also understands what the criminal legal system looks like. I will just say one other piece that has required education that I didn't necessarily expect. I think intuitively, if you think about it, you understand this, and that has really been the clinical systems themselves. And what we saw was when we went in and we talked to individuals working within MOUD offices, some of them said, I don't want to work with the court. I don't believe in what the court is doing. I believe that there is going to be harm that comes from me collaborating with a court. And what actually happened is we said, why don't you join us for a recovery court session? Why don't you talk to Joe about the work that he's doing? Why don't we teach you about what some of these programs look like? And you could potentially, if you want to change it, you could change it from the inside, but you can also understand what it means to be working with this. And so what has been really nice is being able to expand the education of the workforce, not simply for the court professionals or the criminal legal professionals, but also on the other side of this to the agencies around what it looks like to be involved in the criminal legal agency beyond sort of impressions that they may have.
Yeah, I think it's great to take that systems and high level approach. You start at one level and you realize maybe we need the agency level, and you start doing education there, and maybe it results in policy change. I think what I wanted our listeners to realize is that when on this podcast we feature pharmacists who provide linkages to care. I do research in connecting harm reduction organizations with pharmacies, with treatment, with specialty treatment, and connecting pharmacies with EDs to provide treatment. It's only natural that folks with SUD are in the criminal legal system, and interacting with all those people. It's always ideal, and even all of us have been patients when you hear the same thing from all touch points. Your family's hearing the same thing, your physician's hearing the same thing, the parent or whoever. You always want to hear the same thing. And I think I'm so excited about your research and Joe's role, because you're sort of there's a gap there, right, in the touch points. And I'm not surprised that when you go to MOUD providers, like, I don't want to touch the courts. And you're like, well, no, wait a second. You need our knowledge. We need your knowledge. Look, we hired this person for this knowledge. And that kind of builds bridges, and really everybody benefits there. And of course, my next question is always about education, because I am a professor and you have teaching roles as well. Is that, where do students fit into this? So what is your experience mentoring students both in this novel research and disciplines? How do you incorporate in your teaching advocacy, both for the patients and for implementation science?
Yeah. That's been really important for me. Certainly the students, I think that the student part has been really wonderful in expanding their understanding what the criminal legal system looks like, right? And to say, you know, again, we all have our own impressions of what each system might be, but then we also have the reality of what those systems look like. Eventually, in the current moment, they are there and they exist, and we sort of want to provide information about how individuals who are involved in those systems will be working within them. And so the education has been in sort of bringing students on board, having them do parts of research, but also in educating the clinicians. And I started sort of down this path. I'll just give you an example where it's been really helpful to have some educational pieces. So, you know, what often happens is that a probation officer will call a clinician and says, hey, has this person been coming to treatment? And the clinician says, well, if I tell you that this person has been coming to treatment, or if they relapse, you're going to use them against this. And in reality, we know that most individuals are in fact going to relapse because that is the nature of substance use disorder. So we now have an individual that has relapsed, and probably the probation officer is aware of it, right? Potentially through urine toxicology screen or however way. Now, the clinician has an opportunity to explain to the probation officer the patient is doing well as could be expected, because this is an opportunity to sort of teach the probation officer, they're not as familiar with it, that relapse is standard, but that the clinic is monitoring the patient safely in the community, right? This is a time to have a conversation. But in fact, what is probably going to happen is the clinician is going to, or potentially will happen, is that the clinician is afraid to have that conversation, because if they say that this person has relapsed, they believe that the person will then be remanded to jail. So the clinician doesn't call probation back for several days because they're concerned. The probation officer now doesn't know what to do, right? The patient has relapsed. It's unclear whether the person is compliant with treatment. And now the probation officer is scared that the person will overdose, which is in our current society is very common, right? The officer has few options: leave the person in the community and potentially have them experience an overdose, refer them to treatment in the community, which they may not comply with, or incarcerate them where the risk of overdose is not non-existent. As we know, there are certainly drugs in carceral settings, but at least they will be monitored 24/7. What we know is that the patient is in treatment and is in fact doing as well as they can, but the probation officer and the clinician have not had that discussion. And if they did, the probation officer, especially those involved in recovery court, might say, hey, let's make sure we're keeping a closer eye during this critical time, but knowing that they're under your care and that you are confident that this can be addressed adequately in the community. Maybe we can try some other type of treatment where they will continue to comply and you can monitor them, right? And so the education in this case is around sort of having clinicians educate the probation officer, but also having them both work towards the same end goal, which is very much the case for both of them, to keep the person in the community while they're being closely monitored.
Yeah, I like how you consider both education to your students and to the other clinicians that you work with, because collaboration and good communication within the team, like between the clinician and the probation officer, can make the world of difference when it comes to patient care. Although it's important for patients to receive treatment for their SUD, sometimes treatment of their other conditions can kind of get put on the back burner. For example, patients not receiving proper pain management while they're on the medications like buprenorphine or methadone for their OUD. Joe, what's your take on this, and how do you advocate for your patients? How do you encourage your patients to advocate for themselves as well?
Well, the good news is recently many of the barriers to receiving treatment for substance use disorder have been removed or lessened. The bad news is there can be barriers for other treatments that haven't been lessened or removed yet. For example, mental health treatments or treatments for pain, as was mentioned. If there are issues identified with a treatment plan that a participant has, I'll answer any questions from the participant and will offer solutions that they can discuss with their provider. Ultimately, any changes are always at the discretion of the provider. But if a participant has knowledge and asks mindful questions, it's usually better overall for the treatment goals for the participant, and also it makes the provider's job just a little bit easier. Encouraging participants to advocate for themselves is a very crucial skill that I'm finding is lacking for many people who are justice involved. The key would be to empower the participant to help them to understand that when you ask a question and receive a no, there may be a good reason for the no, and they need to resist that urge to take it personally because they've been told no so many times that they immediately just get so frustrated. I'll give you one example. There was a participant who was gaining weight. And it was mentioned during one of the sessions, can you review medications with her? I said, sure. So I sat down and reviewed her medications. One of the medications was known to cause weight gain. The participant stated, okay, I'll just stop taking it. And I said, no, that's not the best approach. Then I went into why stopping the medication without notifying the provider is a bad idea. And I gave some examples of why it was such a bad idea. So you're on a lot of other medications, for example, and if we stop this one, they might adjust other medications based on how your outcomes are or how your behavior is based on taking that medication. If you're not, it can throw all that off kilter. There's possible withdrawals. There are medications that if you stop, you can actually get withdrawals, and you don't want to go through that. That would just make things even more miserable for you. And again, I was able to discuss there are other medications that can work to the same a goal that the provider wants and that you want the medication to do that will have without that particular side effect. But the provider needs to be aware of any side effects that you're suffering. And if you bring your concerns to your provider, they'll work with you. But if they're not made aware that the medications are affecting you a certain way, or if there's problems, you don't just stop it without communicating. The participant met with the provider and had the discussion at their office visit, and they ended up changing the medication to something else in the same class that didn't have the weight gain. So that was actually a success story, I'd say.
Yeah, and I think everyone needs to know that, like, this is what pharmacists do in clinic settings. So it's just equalizing healthcare. I mean, all this is about, we know there are gaps in access to MOUD and healthcare, and particularly affecting marginalized groups like those involved in the criminal legal system. And so I think it's really refreshing to hear, like, oh, you're a pharmacist being a pharmacist, but for this greater need, right? There's just such a large gap that you've identified that we could have a whole direct system of students going up there and helping out in all the mass specialty courts. Would be my dream here, to have pharmacists and pharmacy students working in that interprofessional setting to really benefit patients. So yeah, so there's lots of impact. We've heard some anecdotes. Kate, you have experience as a evaluator. Can you tell us what Joe's impact has been so far?
Yeah, I'm wondering if I can actually ask Joe for one example as where, when we think about advocacy for patients, it's oftentimes sort of, standing up for sort of understanding what they need to be doing. But in this particular case, it often includes sort of speaking to the probation officer or the treatment team, which is what specialty court teams are often called, about a history of their medications. And something that they may in the past have considered sort of problematic, if they really describe their use, that it's going to be held against them, in this particular case can actually be used to interpret what's happening with them now. So Joe has had multiple examples where an individual will come in and say, in the past, I was using long-term medications for opioid use disorder that may not have cleared out of my system yet, or I used a very large amount of a drug that sort of may take a while before it comes out of urine toxicology screen. So I'm wondering if Joe can give a couple of those examples about how that has been useful in interpreting information that probation officers have in making decisions about what to do with a participant.
Oh yes. One of the most common ones was when people were using the long-acting buprenorphine injections for a few months and then they stop. you could still show a positive urine screen, for that buprenorphine, 8 months later. And it's already outside of the mindset of the probation officer saying, yeah, you stop taking those injections, there's no way it would still be showing up when we're checking you. But the science goes right to the fact that that can be proven, and that's actually, can actually happen. There's been, like I said, a lot of there has been a lot of the work with urine toxicology as well, where medications that are prescribed, even aside from mood, there might be other things like antidepressants, Wellbutrin, your bupropion. So someone might take that, and if you screen them, they'll show a positive for amphetamines. So then they'll say, "Oh, so what amphetamines are you taking? You're taking meth, or what?" You kind of, people will jump to that conclusion. Whereas what I'm able to do is I'll say, "Okay, well." People will say, I've got a positive for this test, right, for amphetamines. And I'll say, okay, please, give me the medication list that they're on. And then I'll kind of go through and say, oh, this is a possible, screen positive. Because again, when you send it out, you'll actually find out a lot of cases, this is a screen positive, but it doesn't mean that it's actually there because the drug was never taken. It just kind of tricks that screen. The screening piece. And then, like I said, there's multiple instances of that as well. Like I said, and the other question too is that I get a lot of is how long can something stay in the system? Because people will admit to use, for example, cocaine use, and usually if you look that up, it's like 4 or 5 days. Well, what if they used a large, almost ungodly amount of cocaine? It might stay in the system for up to 10 days. So you have a probation officer that's saying, okay, well, you're saying 4 days and we're on day 6, so they must be using every day. But again, you kind of have to look at each individual case separately, and you go where the science takes you, and you have to kind of look at it from a pharmacist perspective of, okay, what are we talking about the dose? What are we talking about the timing? What are other things going on? Maybe other medications are hindering the release of it, or there's all those pieces that we've all been trained as pharmacists where we really can make a big difference in people's how things are extrapolated and interpreted.
Sounds great. So we got lab test interpretation, med reviews, we got all kinds of things. So Kate, you want to jump in and say where we're going next?
Yeah, so I'll get back to your question about, the evaluation and what has it meant to have Joe. I think it's been tremendously helpful, right? When we originally put the grant in, without even sort of including Joe's component, we thought, oh, we're going to come in and we're going to do these hour-long training sessions, and we're going to put on really awesome PowerPoint slides, and that's going to be great. But nobody wants to learn like that. And in fact, most individuals that are professionals that are working within the criminal legal system at this point have had some exposure and some training around MOUD. What you want is exactly what Joe was describing, right? Which is that they're going to be unusual cases. And so instead of sort of having this automatic response, which is this person should be incarcerated, how can we sort of provide assistance to the criminal legal staff around what to make of this information, right? And so that is what he has been doing. We have had sort of experiential learning as part of the work that Joe does. Instead of saying, hey, here is where the methadone clinics are, here's how you get to them, and let's go on a tour. And I think that's actually been one of the most powerful changes that we've observed when we had judges and probation officers and parole officers who may have heard of and even been outside of those clinics many, many times, but have in fact never visited. And the most common response that we get, I will tell you, is they walk into the clinic and they say, oh, this is like a doctor's office. I would say, well, yeah, all those PowerPoint slides that we told you, remember that this is really just a medical facility. People don't believe that, right? Because you have certain impressions. And so what's been helpful is having Joe there and say, like, here, this is how it works. And then we have the clinician say, oh, the court actually cares, or parole actually cares. Like, they want to understand what we're doing. And then sort of trust is infused into this relationship, because now you know that they're not sitting there sort of handing out random amounts of methadone, that in fact it's incredibly highly controlled, and that there are many clinicians that are monitoring what's happening. And so that has really been incredibly helpful as well.
I think those are all really great examples about how Joe is able to go above and beyond for his patients. And as you were mentioning, building that rapport within the community, not even just between patients, but between the clinicians and other roles as well, just allows them to gain their own experience, and it's just beneficial in the long term. So, Joe, your role in specialty court is also great because it creates that pharmacist position to integrate a medication expert who's accessible for the patients and would be to these patients who would benefit from a consultation as well. And pharmacists are known to be the most accessible healthcare providers, and integrating them into the criminal legal system maximizes access to their wealth of knowledge. You were in a hospital-based clinical pharmacist position previously. Did you notice any similarities between that job and your current one so that you could use your skills to help transition and maybe even define this new role?
Yes, I will tell you, I did spend a lot of time as a clinical pharmacist, and I was never shy about walking into a patient room to ask them questions about their home medication regimens or provide education for current treatments. Additionally, in my role as a clinical pharmacist, I worked with all different disciplines. I worked with providers, NPs, PAs, physicians, medical students, interns, residents, nurses, respiratory therapists, occupational therapists, physical therapists, case managers, and social workers. So if you look at the various roles of people in the courts, it kind of mirrors this because it's all different disciplines. Everyone brings something different to the table. I also provided education and training to those multiple disciplines, and that's continuing in my current role to the courts. The role requires an ability to ensure that information is shared and can be understood by the target audience. I think this position has been a logical next step for my career. I've been fortunate to have worked with many outstanding mentors over my career and have been able to bring all the great skills I've learned into this current role. Education is provided in several formats. I wanted to bring that up. There's the in-person discussions, distribution of one-page educational sheets on various topics, for example, stimulants, gabapentin. If someone has a question about something, we'll put together this one-pager. There's telephone consultations where people will call me and say, hey, can you answer a question? So we'll go with that. I've done webinars on various topics, which include medications for alcohol use disorder, which are very underutilized, treatment of pain management for people with substance use disorders, and an overview of buprenorphine and naloxone. It was right when all the naloxone was changing and the X waiver was happening with the buprenorphine. I also have virtual office hours monthly set up through the COE, the Center of Excellence through Trial Courts, where people who are affiliated with the courts can do the webinar and via Zoom, and we can communicate. They can ask questions, and it's like a good resource for them.
Yeah, it almost sounds like an echo program, and I appreciate Joe shared me some of the sheets he's done, and they're phenomenal. And I think it's really knowing your audience, and the audience knows you, so they don't just get a sheet with your name on it. They know you from these other sessions. So I'll switch back to Kate. So how have your expectations changed for the position, and how was your impression of pharmacists? How has that changed? You're not trained as a pharmacist, and you're working with Joe here. It's been a while, so tell us what you think about that.
It's been absolutely tremendous. It's been so wonderful to be able to learn from Joe. And, I will say, so there's certainly expertise, and then there's knowledge, but there's also the training that you all receive during your schooling, which is exactly this, to be able to teach others about different medications, which is really not as common in any other professions, right? This is sort of a critical component that is often left out. So once we realized that this is sort of where the gap was, what we saw, the biggest change was that there wasn't enough of Joe to go around. And we have had so many people reach out to us and say, wait a minute, why does this court get Joe? Or why would you have this community agency that have it, but we don't have access to him? And that is because first it's because of Joe, who is an incredible human and really sort of does some wonderful work. But really it's because there's this sort of underutilized skill set and knowledge base that you all have that has really not been integrated into the criminal legal system. And so that has been the biggest sort of lesson for me, which is that we need many more people with this particular skill set to be able to work as translators, as liaisons between the different systems to ensure that individuals who are being monitored by these systems sort of understand the importance of these treatments and how to access those treatments, and that those systems, the clinical systems, are similarly recognizing the importance of sort of communicating back with the criminal legal agencies.
It's amazing how you've been able to incorporate your new role so much and how there's so much interest from those that you work with in kind of scaling up the role. That's really great to hear. Just wanted to switch gears a bit. I had another question for you, Joe. Could you provide a basic description of what happens when people are released from prison or jail and how you work with them at that point, especially to ensure that they have an uninterrupted supply of all of their medications, including those for opioid use disorder, the MOUDs?
Yes, I'd actually change the question around just a little bit because it goes beyond just parole. I work together collaboratively with community agencies and probation and parole and the community providers for the mood. As part of my role, when I was embedded in the recovery court team, I act as a liaison and educator, but I also will spend time connecting, as we talked about, the community mood providers to the court staff, but also the parole, the probation. You know, we do a lot of the building bridges and as has been explained previously, getting people to communicate with each other, explain what everybody does. You know, so, and the agencies, believe it or not, beyond parole, have actually reached out and asked me questions about urine toxicology screens, medications that cause a false positive, like we talked about. And these are community providers that are reaching out. So again, you know, as you're there as that, you know, that medication content expert, and you're helping everybody, and again making sure that everybody has access when you're that's one of the first questions that the people in parole and probation are making sure, okay, how are you on your medications? You know, are you having cravings? Are you doing well on your treatment? So, you know, a lot of times if there's something that comes up, I can kind of get involved and help make sure and bring down barriers to make sure people are getting everything that they need for treatment.
And just building on that and thinking more about when someone's first released from prison or jail, naloxone is really important for patients with OUD to have readily available to safely and effectively reverse opioid overdoses. If they do encounter that, what role do you play in making sure your patients in specialty court or those with OUD who were just released have access to naloxone?
All right, well, I will tell you the one big thing that was surprising that I learned when doing this work is, and there's different studies around, but there are people released from jail or prison in Massachusetts. The initial release time that they're out, they're 120 times more likely to overdose on opioids than the general population. So this is why both mood and naloxone are so important. The treatment for mood is protecting, and the naloxone is protecting as well. Naloxone is available to participants in three ways. I think we all know this. Either you can buy it over the counter now, where it's about $48, I believe, for a box of two. You can ask a pharmacist at a community pharmacy to fill under the statewide blanket order in Massachusetts. And if you have insurance, they'll bill it to your insurance, and there's a copay. And assuming the participant will have active insurance, because sometimes people may not have active insurance when they're leaving. And then you can get it by community access programs, which would be the free, you know, and again, if it's free, it's for me. I'm a big fan of free. There's not a one size fits all approach. So I kind of advocate where and when I can. You know, somebody, a lot of times these community partners are involved in the court sessions and with parole, and we build those bridges and we can connect them for those services. But again, it's not a one size fits all. Certain, you know, jails might distribute, certain jails may not. They might connect you with the community resources. But again, I just advocate to ensure that everybody has an naloxone because it's so critical.
Yeah, I think those are all great points. And as a student, I think quite similarly, since we know there's different options on how to get a naloxone kit, but it depends on the setting and the patient. Because there are times when I dispense naloxone right from my pharmacy at work, but there's also other moments when I refer my patients to get their naloxone through the community access programs here in Rhode Island. And so, just considering everything we've talked about today and how your role has made such a great impact, if you could replicate your position, Joe, would you, and why or where?
Yeah, so I'd want to figure out a way to expand the position to bring the work to everybody across the entire state. Of course, it requires a lot of coordinating between the courts and the community providers, because you start to think Massachusetts is a relatively large state. There's a lot of various community providers and a lot of bridges and a lot of relationships to make. Um, let's say and also if you were to be embedded into the court team meetings, in the court sessions, you'd want to attend those. So many courts will meet on the same day. So you'd actually need multiple. I can't be in two places at once. So you would want to make sure that that you have more positions like me to be able to work regionally, maybe break them up into different regions, which is how I would move forward with this.
Kate, you want to react to that?
I do. Yeah, Joe's absolutely right. There's very much room for expansion and there's interest. But, as we talk about advocacy, where I see another piece of this really in being is in pharmacists advocating for the role as the liaison between these two for agencies and federal agencies, for state and federal agents to be able to reimburse the work that they do, right? We have found that there's a critical gap of this knowledge and skill set that is necessary. We are also incredibly fortunate to have been able to use some of the funds that we received for research, but also the incredible support that we have had from the state of Massachusetts and the sort of powers that be that understood the importance of having pharmacists in this position. And so I know that we are very fortunate. That is not going to be the case for every single state. But what I also see is that given the incredible expansion of medications for opioid use disorder in various settings, really this is going to become more and more critical. And so advocating both to and from these agencies, but also at the state level to be able to get some funding towards developing these roles.
Yeah, let's hope BSAS is listening, right? So yeah, totally understand. And I think another interesting thing that I'm reflecting on is, Joe isn't sitting in the court every day, right? Just as pharmacists are often in pharmacies or have to be in the hospital. We're doing, what Cassie and I do, or what I do with public health, or you can create educational materials and phone in support. So I think the flexibility and the expertise, it makes sense. I'm sure someone could do a cost effectiveness study to say, like, providing this knowledge really helps down the line, prevents reincarceration. Those are great studies to do, but I think now is the time to do it. So, Kate, what is the regimen for pharmacists and pharmacy students to help support people in the criminal legal system with substance use disorder?
Yeah. So ideally, we would have a pharmacist, a substance use disorder expert available to each court and criminal legal agencies to be able to consult, to educate, and to serve as a liaison. As I've already mentioned, we're sort of entering a new era where MOUD is the standard treatment for individuals with criminal legal involvement, and yet expecting that individuals that work in the criminal legal system have complex understanding of pharmacology and have the ability, the skill, and the time to establish liaison relationships with community providers is unrealistic and probably an ineffective way to use their time. And so our systems work well, bring in experts and consultants who are available when needed. In time, those experts can increase the overall knowledge-based comfort and skill set, but it takes time, and it probably takes years to be able to see those things sort of pay off. And I don't think expecting that simply removing prohibitions on medications for OUD is enough. And that is in some ways what implementation science, and I know you know really well, teaches us, right? We can have effective treatment or approaches, but unless they're implemented in a way that fits the confines of those systems, we're not going to progress to see the progress that we want to see. And in this particular case, we need to be able to work within those systems. So what I see is that pharmacists have incredible expertise that most individuals in the criminal legal world lack. Your work can be highly complementary and used to ensure greater access to care for individuals most in need of treatment. Working with legal agency does not have to be in traditional ways. You can figure out how you can address the gaps creatively and hopefully with the support of large systems that will be able to pay for the work that you are doing. Remember that there are many different ways of helping individuals with criminal legal involvement and struggling with substance use disorders. And I think one of those is to work with agencies that supervise and support make sure that the best care possible for our most vulnerable individuals, which are those who have criminal legal involvement and who are struggling with substance use disorders.
This has been such a great conversation today, and I'd like to thank our incredible guests, Dr. Joe Sawicki and Dr. Kate Pivovarova, for joining us and providing great expertise and insight through our discussion today. You have both made such great contributions to the community and are continuing to do so. Thank you so much.
All right, thanks so much, and be sure to follow us at PharmD Pub Health. That's Pharm as in pharmacist, PHARMD Pub Health, all one word, on Instagram. Connect with us on LinkedIn, and turn on post notifications wherever you sign up for socials so you never miss an episode. Smash that subscribe button now on Spotify, who hosts us, Apple Podcasts, YouTube, Amazon Music, or wherever you listen to podcasts. Thanks so much.